cohorts to generalize this across all critically ill patients. It's a pretty important study to be familiar with. So we're going to get some fluids going. Now, riddle me this, access-wise. Can you put IVs through burned skin?
Yes.
Absolutely. You prefer not to, but if that's the boat you're in, it's better than nothing. What if you've tried for a couple minutes and you cannot get an IV to save your life? You drill, right? Humeral head, whatever your protocols are. I'm a big fan. I was lucky enough years ago to briefly be a vendor rep with Teleflex at that time, and got to go to a cadaver lab. Has anybody done one of
We did
these?
it at night. We had them come here and do it at night.
Isn't that great? Did they do a cut down? Did you see this? This was amazing. It changed my perspective forever. Where they cut down so you could literally visualize the subclavian vein. And when they would do that, the flush through the humeral head insert, it was like an anaconda swallowing a groundhog, right? You could literally see the bolus going through the subclavian. That's what we say, peripheral access, central circulation. 3 seconds after you push, you're in the vena cava and being circulated. So, big fan of IOs when it's the appropriate tool. All that to say, get you some access and lots of it as needed. Now, if this is a 5% burn, okay, maybe you don't need to have 6 IVs in an IO for a small burn. But for big traumas, plenty of access. Get something going based on the age. Now, if you have a 12-year-old who's bigger than me and looks like he could deadlift a tractor, we'll treat him like an adult, right? So, but for smaller kids, I'll also add this caveat, because this is resuscitation fluids. Now, to get specific, resuscitation, what's it for? It's for replacing the intravascular volume that has been third spaced out into the tissues. Does that make sense? So that's replacing what was lost because of the increased capillary permeability, all that. That's different than maintenance. This is like basic metabolic needs. Why for small kids would I want to include dextrose in basic metabolic stuff? Yeah, they're going to burn, because they're smaller, they're going to burn through sugar quickly, higher metabolic rate, lower fat stores, immature liver. All of these reasons, they can bottom out their blood sugars very quickly. And again, think warm, pink, and sweet, warm, pink, and sweet. So you stave that off, adding however is expedient. If you don't have D5L on the truck, you're paramedics. You guys are expert ninjas on finding ways to improvise to figure out what's going on here. So that might be many boluses of an Ampy 50, whatever. But you want to keep their sugars stable and not hypoglycemic, okay? Notice I still haven't talked about the size of the burn, right? Because this is still my primary. I'm going to get something going. I'm going to defer my burn map until I've addressed the life-threatening stuff, which is A, B, C, D, E. All right. The short version for disability, neurologic deficit disorder disability, is if they're not alert, something's going on, figure out what it is. The burn itself isn't necessarily going to cause altered mental status, but something else may, many of the suspects, etc. Sometimes it's more than one. All right. Expose and examine. You'll want to expose the patient, not yourself, because you will get written up for that. Please be careful. All right, signs of life. I was just seeing little joke grenades to see if you guys are still in. All right. So, remember, killer bleeds, right? So we've had 3 opportunities to look for the life-threatening hemorrhagic stuff that's going to kill them right now. That was when we first eyeballed the patient, when I formally got to the circulation part, and this is my last chance to look for the stuff that'll kill them right now. So I don't notice until I look at their back that, wow, there's a big exit gunshot wound right there. Or look at that knife right there. What do you know about that? So we're also looking, finally, to answer the question of how bad is the burn. Because again, I'll impress upon you, burns can kill you, but in the first few minutes, it's not the burn that will kill you. So you look for other polytrauma stuff. Why does the jewelry have to come off? Wrong. It's because we're getting close to the holidays and you want to sell that little stocking stuffer. They're intubated, sedated, they don't know. No.
You get accused enough of that.
I'm sure you do. I'll tell you.
Cemeteries.
Yes, sir. Well played, sir. Well played. I'll tell you, in
Most
terms
times
of
it's dentures though.
okay. Isn't it though? Right? Oh my God, we got stacks of dentures. We look like a fun house of some stuff that's not claimed or whatever. I had a fellow one time. We were getting to the point where we weren't sure if we were going to be able to cut the ring off because he had delayed coming in and the edema was already severe. And if it ever changed how I talk to patients about it, I'm like, look, the swelling is getting really bad. We're going to listen. You need to help us here or we're going to have to cut it off. Now he freaked out. We had to call a behavioral response. I was talking about his ring. He thought I was talking about his finger.
First one and then.
I know, right? And he was thinking worst case there, but I have tried to be very mindful about how I talk about it going forward. Now, once you have taken a look for any other life-threatening injuries and assess the burn, which I'll get to in a sec, the overwhelming priority is warm. You've got to get them warmed up again. Concept, trauma triad of death. Okay, the things that will kill patients dead in short order that are self-reinforcing, bad prognoses, if they're cold, acidotic, and coagulopathic. You're not going to control coagulopathic in the field. You're not going to control acidosis probably, but temperature, now you have some control over that. So try to interrupt that part. This goes back to, you mentioned early on ice for treating. If it's a very small wound, a little bit of ice for a short period of time may help with pain management. The big concern that we have with ice or even cold water or even room temperature water is it's going to reduce heat. Now what's the body going to do to adapt? Vasoconstrict, so perfusion is going to take a hit, which means your second degree burn converts to a third degree burn from poor perfusion. Does that make sense? So that's the concern over time.
Sesame Street Live.
What, say again?
I said Sesame Street Live.
There we go. Whoop, whoop.
Yep. They have this video about burns and Sesame Street always saying pour water over it.
I'm gonna go kick the crap out of Big Bird right now. If they're actively on fire, great. If it's a small burn, great. But beyond 2 minutes out, it's so interesting, the thermal transfer of heat after about a minute or two, the thermal transfer is done. So adding a water doesn't help at that point. I'm beating a dead horse, but you guys get it. Please convey that because we routinely get folks who they've submerged it or run it for 30 minutes or whatever, and the burn is worse than it would have been otherwise. And when you see Big Bird, just like that, right?
There you go.
There you go. All right, so we're going to warm them up. All right. Also, clean, dry gauze, again, steer you away from wet wraps, wet dressings, etc. Now, all of this was all about the primary for the life-threatening stuff. Finally, assuming we've addressed the life-threatening stuff that'll kill them in the first 15 minutes, now I can stage my burns, okay? But don't let the burns distract you. I've said it like 14 times. I hope you follow that. That's an important concept. So let's agree that all burns aren't equal. Of 2% burn for me might be life-threatening for an 80-year-old. Conversely, a palm-sized burn on my abdomen would be quite different than a palm-sized burn on my face, for example. So location matters. Of course, we know that the size of the burn is significant as well as age, but if this is a CHFer with diabetes and all of the things, they're going to have a rough go of it with even a small burn. Okay? All right, so a little bit of anatomy because it drives how we describe burns. Our problem is you cannot see this, right? You're making inferences about the skin based on what you see from the outside. But I want to keep this in mind when we start looking at pictures of skin. So the topmost layer, and the analogy that I'll make is, I like thinking of the epidermis as the skin of the apple. It's the outer wrapper, if you will. It's very thin. How thin? Well, answer A is it depends. It's a bit like the odor of a nursing home. Another little joke. This call and response. This is my checking for, that's my AVPU version right there.
Nice.
That's a pretty good one. I like recycling that one. It's a nice, you just let it breathe.
That was good.
It's good. So, where on your body is the epidermis the thickest? Yeah, hands and feet. And more to the point, palms and soles, right? Because if we think about palm versus dorsum, quite different. Does that make sense? Because this is a high friction, high touch area. On purpose, it's very thick epidermis because there's mechanical, all this kind of stuff. This loops right back to your homework tonight, which is what? Check your smoke alarm and practice your plan. If your smoke alarm goes off on the other side of your closed bedroom door tonight, what are you going to do? You go check that door before you open it, right? And we counsel folks to not check it this way, but to check it with the back of your hand.
That's why I don't sleep with a closed door.
Say again?
Listen, that's why I don't sleep with a closed door.
That's a whole other extra credit maneuver, but the idea to get out of the house, you want to see what's on the other side of that. You will feel heat, pain through this thinner skin a lot more quickly than you will through the thicker epidermis. Does that make sense? Let's also agree that the skin is variable for dermis. Where on your body is the dermis the thickest? Well, that's your back and your butt. But let's agree that is much thicker than, let's say, your eyelid, as an example. So the location matters a great deal. So you can flip this around a bunch of different ways. If I'm exposed to tons of heat, likely is the thinnest skin is going to be the most severely injured. Does that make sense? But we flip it around. If a person has a full thickness burn to their back, by God, that was some heat for a long period of time. Does that make sense? If it went all the way through the thickest part of the skin. So you think about it both ways. Kind of the same way that you can think of pressure and volume with lungs, that inverse relationship here, okay? So the skin of the apple is the epidermis. It's always dying anyway and conveyor belting off. I'm not as worried about the epidermis, but I do start to worry about the dermal layer underneath. That goes from the skin of the apple till I'm in the meat of the apple now. Okay, it's a metaphor. I'm in the meat of the apple, and I have the skin cells proper, but I also have specialized structure. I'd like to bring 4 to your attention, 4 specific specialized structures in the dermal layer. What do you see? What lives in the dermis? Blood vessels. Blood vessels. That, my friends, is cap refill. Right there, when you measure cap refill at surface, you're not, well, if you do cap refill, that is not your femoral artery that you're measuring. It's surface arterioles and venules, okay? Which means if the burn has gone deeply enough to compromise the surface blood vessels, you will have either diminished or no cap refill. But you won't know unless you touch the patient. Okay, I'll say this 18 different ways. You got to touch them, not just look. You got to touch them, not just look. So blood vessels. Keep going. What else do you see?
Nerves.
Yeah, so I hear nerves, okay? If I'm confined to the skin of the apple, there might be some pain, but if I get down into the apple, any spinal tap friends? And this is spinal tap? I'm dating myself. No?
Going to 11?
Our pain goes to 11. You know, like it's a whole different world of pain. Conversely, if I keep going with the burn all the way through the dermis, all the way down to the subcu fat, and the nerve endings are wiped out entirely, I may have no pain at all. Does that make sense? Now, not that I'm a sadist, but it bothers me more when the patient doesn't feel pain. Okay? Not that I'm trying to hurt them, but I need to know whether they can feel this or not. So, blood vessels and nerve endings. Keep going. What else do you see?
Sebaceous glands.
Yes, sebaceous glands, okay? So that's the oily substance and the kissing cousin, sweat glands. Those two are fairly related. Turns out for deep burns, those glands won't work the same as they used to, which means this patient in the long haul is going to be at risk for overheating because they can't sweat, etc. Not my concern for emergency, but it's interesting to know. Big burns, they're going to have problems with hyperthermia for the rest of their life, assuming they survive, etc. What else? There's one more, near and dear to my heart, hair follicles, since I'm losing most of mine. Woo! Right?
She only said it about 15
I'm sorry.
I said that.
Well, along with me losing my hair follicles, I've lost my hearing as well, so it's apologies. All right, it's not even age, it's the fact that I have 4 kids, and I'm like,
We call those man ears.
Yeah.
You have your man ears
What?
on.
what?
Yeah. Now he's part of this thing.
Selective hearing, right? So the hair follicle is in the dermis, and this is the root. And it's going to sound like I'm making this up. I am not. Here on the left, slightly above the root, you see kind of a little bulge. I shit you not, it's called bulge cells. I could make this stuff up, right? But more to the point, what's in that region is progenitor stem cells. Now, why does that interest me? Stem cells. Yeah, so that's the specialized cells that are like blank templates. And they're going to differentiate, specialize into all the other specialized structures. This is where the regeneration of new tissue is going to come, okay? Unless the burn goes down deeply enough to wipe that out too. And then that area of burn tissue will not heal from the bottom up. Does that make sense? It cannot heal from the inside out if the burn is too deep, okay? Which is why we make a big deal about partial thickness, 2nd degree, or full thickness, 3rd degree. If you're 3rd degree, you've gone all the way down to the subcu fat, you've wiped out your chance for healing from the bottom up. The only way to heal is from the edges in, from the nerve, or the nerves among you. That's what we call secondary intention, right? The primary, secondary intention to the wound's edges approximate. Do you have a collagen matrix across and all that business? You can still heal, but it takes a lot longer. The wound is open for longer. Here's your the risk of infection. Here's your scar bands and your contractures and all of that jazz. So that's why we worry about 3rd degree so much more. It's going to take longer, worse functional cosmetic outcomes, etc. And you've lost, sensation, your sebaceous glands, sweat, all that stuff. Just makes sense so far? So that's the anatomy cross-section. Now, once you've gone all the way through the dermis, now you come to subcutaneous fat, subcu fat, and if a hypodermic needle goes underneath the dermis to the subcu fat, etc., etc. What's below the subcu fat? Well, ultimately bone, right? But connective tissue, muscle, bones. Okay? You can have more than a 3rd degree burn. Okay, across the pond in Europe, they call that 4th, 5th, 6th degree. I just say in Latin that's called bad. All right, after 3rd degree, it's very bad. Okay, but the concern is, will it have a chance of healing on its own? That's why we play the game. The problem is, I can't see this. I don't see the cross section. I see this. So the trick is, make inferences from what you're seeing and feeling about what that's telling you about the specialized structures that matter to us. So, in a classic sunburn, and I say classic because, let's be honest, if you're determined to lay out at Myrtle for 8 hours in August, congratulations, you look like a lobster that's molting. Here's your really bad 2nd degree burn. It's terrible. So I say classic sunburn, where you have, it is painful, I'm not gonna lie, painful, but your skin is still intact for right now. Again, 3-4 days later, it is going to slough off. We talked about that. But right now, the skin of the apple is still attached. That's a key point. The skin of the apple is still attached. The epidermis is still bound to the dermis. It's painful. It's red. Might even be swollen. But here's your ibuprofen, your Tylenol. And this is what we would call a gomer. Do you know what a gomer is? Get out of my ER. Get out. Nope, we're not giving you 10 of Dilantin for that. Get out. Not clinically significant, and here's the big newsflash for some. Do not include 1st degree in your burn map. Do not include this and when you talk about how big the burn is. If it's 1st degree, don't include it. Okay? Had a fellow flown to us from the coast via fixed wing. described to us this is a 90% burn. His propane grill blew up in his backyard. 90% burn. We're like, oh my God. We get the room ready, ICU, move patients around, get the ventilator and all this. He comes in, he's sitting up on the stretcher, chatting with the paramedics. And I'm like, what? And I'm looking at him. Where'd the burn? Where'd the burn? It all looks like this. That was not a 90% burn, that was a 0% burn. Flown from the coast for no reason there. Because again, they were looking, but not touching, and weren't really assessing very deeply. It's a flash burn, it is what it is. Don't include first degree. Don't include first degree. What happens when you penetrate it through the epidermis into the dermis? Well, now you're at least to second degree. Most important word on this slide is blister. The hallmark of second degree or partial thickness, and I say partial thickness because I'm partially into the thickness of the dermis. Not completely, that's third, but I'm somewhere in the dermis, but it's blistering. Our pain goes to 11. There's cap refill. What does that tell you? They're still perfusing, so we got it. So you're telling me I got a chance? Yeah. Another little cultural references. Right? What else? It's moist. Okay, now let's take a look at this. Is a picture of JJ again. We take a picture here. Now, if you'll notice, if I point like right here, this part of his skin, it's dry, it's, normal skin tone, doesn't seem to be erythematous. This is normal, healthy, uninjured tissue. Do you guys buy that? Not burned. I make it over here, and it's red, probably painful, but the epidermis is still attached. So I transition from not burned to first degree. You guys catch that? I keep trucking, and now I have blisters. And the blister can look a lot of different ways. You can have an intact blister that still has the cap, whatever you want to call it, or it can be unroofed or reduced or popped, whatever language you want to use, where the roof is gone. If the roof is gone, what's left and exposed? What am I pointing at here? That is the dermis. Does that make sense? Epidermis is gone. The skin of the apple's gone entirely, exposing the meat of the apple. Does that make sense? Now, why moist? One function of the epidermis is to keep moisture in. Serous fluid. If enough insult happens, whether thermal or otherwise, if you grab the rake to rake leaves in your lawn and you haven't done that in a while, or you grab an axe handle or whatever, you might end up with blisters. What's a blister? It's some kind of trauma, mechanical or thermal, that separates. It's enough to separate the epidermis from the dermis. The two separate, and in the space between, serous fluid collects. That's that yellowish fluid that's in there. That's all a blister is. Epidermis separates, serous fluid collects. But it's moist. It's moist. The heat has not been hot enough or sustained enough to evaporate all the moisture. If that happens, if it's hot enough or long enough contact to evaporate all the moisture, you get this. You go from medium well to well done. There ain't no pink center no more. It's all gray, by analogy. So I do not know whether this is African American or Caucasian patient. This black is not normal dermal color. This is charred. This was epidermis. It was epidermis, however, the heat was enough to separate it entirely and progress to the dermal layer. So this white khaki tan stuff, that's the dermal layer. Does that make sense? So the visual appearance could be charred black, white, khaki, pearly white, tan. You could also have pink or cherry red. What's different about this fine, slam the door. Some people, geez. What's different about this pink compared to this pink? Because this is also pink. How are they different?
Being infused.
Well, yeah, this one is still being perfused, and how do you know? Because you touched it and saw that you still have cap refill, right? That's one thing. It's still being perfused, still has cap refill. This does not have cap refill, and it's dry. It's dry. Why is it dry? The heat's been long enough, sustained enough to evaporate all the moisture. But again, you won't know unless you touch. There's less pain or no pain at all. Again, that's a sinking feeling when you're poking, prodding, and they can't tell the difference. There is no cap refill whatsoever. Why skin grafting? Because otherwise it's got to go from the edges ends, take a hell of a long time, etc., etc. Does this make sense? There's multiple problems. Number one, usually it's not all one or the other. Often it's a mixture of several. We'll talk about what to do there. But again, this is, the touch is just as important as the appearance. Okay? So first, second, third degree, that's not included. That is, and that is. Does that make sense? So don't include first degree, but do include second, third degree. What you do now is you add it all up. And y'all knew rule of nines before you ever met me, right? It goes something like you take the body, divide it into multiples of 9. On an adult patient, whole arm and nothing but the arms 9, whole leg but nothing but the legs 18, whole anterior torso but nothing but the torso is 18, etc. Sorry, gentlemen, it really is only 1%. But there's two problems with the rule of nines. That is my reliable laugh. Out of the whole 4 hours, that's the one chuckle. Generally speaking, that's always going to give a laugh. So there's two problems with the rule of nines. Number one, children are not adults. And the smaller the child, the more divergent they are from this. Anybody with a very young child? When they're born, right, they look like Wendy's bobbleheads, right? They got fat melons, right? And their neck control is like somebody in one of my classes towards the end. They're like this, right? About to pass out at any moment. That's problem one. Newborn, head's 25% of their body. By the time you're an adult, 10%. Okay? The proportion is different. That's problem one. Problem two, almost never is it the whole limb and nothing but the limb. It's usually more complicated. That's the two main problems with rule of nines. But that gets you in the game for a broad brush. It's a shotgun approach. To get more precise, we played door number 2. Now in your packet, I want to say on the second or third page, I give you a blow-up version of this. And when you flip on the light so they can see their, thank you, Fred. I'm just checking for people or response, and everybody's like, yeah. So you guys have a version of that, yes? All right, so remember I said there's two problems with rule of nines. Number one, kids are different than adults, so we've solved that with columns by age brackets, okay? What was the other problem? Usually it's not the whole limb and nothing but the limb. So we take the arm and divide it into upper arm, lower arm, hand, take the leg, thigh, lower leg, and foot. Does that make sense? That's the idea. Notably, when we're shading this, my key up here, you see the diagonal slashes when it's shallow, pink, painful, moist. What does that remind you of? That's the second degree. That is second degree. It's different wording, but it's second degree. What's next? Indeterminate, deep, dry, less sensation, white, mottled, dark, red, brown, or black letter. That is classic description of full thickness or third degree. Notably absent, first degree. It's not on there. Don't include first degree. How do you differentiate first and second degree? Because both both blanch, both are painful, but it's the blistering. It's about, is the skin of the apple, is the epidermis, is it really attached, or is it only fake attached? Does that make sense? I'll give you another example. Did I talk about my 60%? Sorry, this is my 4th time with this class. Did I talk about my 60% burn and the degloving? All right, that was the morning. Okay. Had a patient come to us, house fire, 60% burn. He's 50 something. This is potentially very serious life-threatening injury. Burn from the waist up. I got him into our hydrotherapy tank room where we do our initial assessment, all this. And once I took the clothes the rest of the way off and looked at his legs, I degloved both of his legs from crotch to foot. I mean, it was like taking off Ted hose. Just came off and, okay? Because just a little bit of pressure and like it was just sloughing off. It was like a stewed tomato coming right off. But let's keep going. I can ruin any food group you like. All right. Speaking of lung butter, yeah, peep not poop. Hug an RT today. There we go. Moving on. All right. But the way that you differentiate, because both will have cap refill, both will hurt, but it's how attached to the epidermis. Does that make sense? But you got to touch. You got to touch. Okay. So let's see if we can interpret this. Okay. Let's say that it's a thigh only for an adult. How much is that? A thigh for an adult. 9.5, right? Okay. All right. Sorry, I'm turning into adolescent humor here. We're talking about food jokes or whatever. I had friends in high school, dumb friends in high school, would call up KFC. Hello, this is KFC. Do you have breasts? Ha 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 ha. Stupid. What can you do? All right. How about for a 2-year-old? Thigh for a 2-year-old. 6.5. 6.5. Does the chart make sense? Pretty straightforward, right? Find the age bracket. Find the row for the particular body part. So this is better because let's say that a thigh for the kid, the thigh's not going to be 9%. It's going to be 6.5, which is, you know, if you multiply that times 4 extremities, this starts to diverge quite a bit. However, as good as lumbar outer is, and I much prefer it, it's still not perfect because usually, as we've said, it's scattered and irregular. And it might not be the whole forearm and nothing but the forearm. Does this make sense? So that brings us to door number 3. If door number 1 is rule of 9s, it's a shotgun approach, better than nothing. Door number 2, much preferred, lumbar outer. Door number 3, fine-tune it with Palmer method. So patient's palm and fingers is approximately 1% of their total body surface area, roughly. And may I ask you a favor to drop the lights again just for resolution on my... This is a blow-up. So this is JJ's left arm, okay? How do you feel about the depth? So I totally agree with that. What jumps out to me is that there's significant swath where there is no skin of the apple. The epidermis is done gone. Right? And this, it's shiny, ergo moist. However, look and touch, and here's why. So, did y'all agree if I call this 9 from rule of 9s, I'm overestimating? Right? Because this is burned up here, right? So it's not the whole arm. So 9 would be too much. Lumbar outer is 2. How much is a forearm? 3, I think. 3 for a forearm?
Yes.
Yeah.
How much is a hand?
2.5.
2.5. Does it kind of make sense it should be around 2 since palmar, dorsum, whatever, and that should be around 2, 2.5? So if I use palmar surface, then I've got, well, about 1, roughly, about 2, about 3, maybe 4, perhaps. Now, I wouldn't want him to roll his arm over because I want to see what's going on with the other side. But that's around 4%, which is, that's less than half a 9. You guys agree with that? So that's the beauty of Palmer surface method versus the other stuff. Now, here's my problem. When I look closely, do you guys see this kind of line of color change here? So this looks like unburned, and this looks a little darker. And again, this is a dark-skinned patient, but it looks like this might be injured here, but could be first degree, right? Except that this is not my picture, not my patient, but I've seen this replicated. This loss of the epidermis, to me, begs the question, how strongly is the epidermis attached? More to the point, down here, right here. Now that really gets my attention. This ain't my picture, but I could so imagine mom or dad grabbing him and pulling him away from the stove, and the thumb, it's a thumbprint. Or a healthcare worker lifting up the arm to whatever and shears right off. Does that make sense? Which to me begs the question, everything around here, is that really attached or fake attached? Does that make sense? You won't know by looking. You have to touch. Does that make sense? Let me be clear. I am not asking you to debride that whole arm. I'm not asking you to deglove anything.